let's go ahead and get started. We have quite a few folks joining us already, but people can continue to trickle in. So thank you and welcome to the first in a series of roundtable webinar discussions hosted by Care Message. I just want to, before I go any further, make sure that I am recording. I am. Fantastic. My name is Thad Kalashevsky, and I manage our free clinic program here at Care Message. Today, our topic is rather broad. We will be discussing the treatment of the social determinants of health with a more holistic approach to patient care. So why this topic and why now? I don't think I have to tell you all about the unprecedented moment that we find ourselves in. The COVID-19 pandemic has affected all of us in different ways and to varying degrees. We also know that the lower income communities that you all serve are disproportionately affected. They are significantly more vulnerable from both a health and an economic perspective. Massive waves of job loss or a reduction in the number of hours worked has led to changes or loss of health coverage. It's led to extraordinary instability in housing as people struggle to make monthly payments. Food banks are reporting a record number of families depending on local pantries as WIC-approved products are picked through, and those that live in food deserts find that they cannot rely on public transportation with reduced schedules or for fear of catching this new coronavirus. Not to mention the effects that social isolation has on the mind. I would imagine that you're already seeing concerns with loneliness and depression and anxiety. And so, as an organization whose mission it is to leverage technology to help organizations like all of yours fulfill the essential needs of underserved populations, we want to make sure that we're doing all that we can to create a space for healthcare professionals, whether you use Care Message or not, to interact, discuss strategies, challenges you've faced, and share with us what's most important to you and your patient community. So what do we hope to accomplish here? We want to foster a productive discussion between all of you, staff and volunteers from health centers across the country, FQHCs, free and charitable clinics, and community organizations alike. We will bring on experts like Brooke and Dr. Revens to talk through how their organizations are thinking about and tackling social determinants in their respective communities. We really want this to be an interactive, roundtable style discussion as well, so we will have time set aside after their presentations to ask questions, bounce ideas off of each other, and give folks a chance to respond as well. Please feel free to make use of the chat button in Zoom throughout the course of the presentation. Ask questions as they come to you in either the chat or with the Q&A button, and Jeremy will be sure to keep an eye out and make sure all of those questions are addressed. We also ask that you go ahead and raise your hand. You can do so by clicking the raise hand button in Zoom. If you're comfortable with voicing your question, your observation, or your opinion aloud, we can go ahead and unmute you then and allow you to participate in the discussion directly. Just make sure that your microphone is connected. So without further ado, we will hear from Brooke Lattimore. She is the Chief Operating Officer at Stigler Health and Wellness Center, a federally qualified health center in Stigler, Oklahoma. Brooke?
Great. Can you hear me?
We sure can.
Okay. So I'm trying to start my video, but it's not letting me. But as long as you all can hear me, that's great. So thank you, Thad and Jeremy, for allowing me to participate in this. I'm really excited, and thank you, Keri, for joining me. So As Thad mentioned, I am with Community Health Center, also known as the Federally Qualified Health Center, here in Oklahoma. We're located in rural eastern Oklahoma. We have about 7 counties that we serve and about 30,000 patient lives that we take care of. So just to get right in, so how do we identify the needs of our patients? We do that a couple of ways. We do use the Prepare Toolkit. If you guys are not familiar with the Prepare Toolkit, it focuses on social determinants of health. It was created by NAC, the National Association of Community Health Centers, and it's an acronym that stands for Protocol for Responding to and Assessing Patients' Assets, Risks, and Experiences. Of course, we all know that in healthcare there's 1,000,001 acronyms, but it asks a lot of questions from food insecurities, transportation, domestic violence, clothing, shelter, have you recently been incarcerated? All those things are identified when the patient checks in through Phreesia, which is our intake software that captures that information. The patient can answer those questions, privately. If they do not want to use the Phreesia intake software, it's either on their phone or a tablet in the clinic. The nurse can walk through those questions with them. I'll be honest that we probably still have a lot of work to do around flagging those patients that do identify themselves as having a need. I know we can get better at that, and I look forward to hearing from all the participants about maybe some ideas that you guys have. So like Thad said, this can be a roundtable discussion, and I look forward to learning just as much from you all. We do have some internal programs that we do try to catch those patients in need. We have our integrated care specialists. Those are typically folks that have a background in case management. Some of them have a background in nursing. Some of them have a background in behavioral health. But they do monitor the intakes of our patients and work with our patient care coordinators, our medical, behavioral health, dental, and optometry teams. So a lot of times those patients maybe come in and they score high on the PHQ-9, which is the depression screening, and those integrated care specialists will jump in and see what they can do to help the patient. Sometimes the patients won't even mention, that they are struggling with housing or transportation, whatever the need may be, but they will score high on the PHQ-9, and so that triggers our integrated care team to jump in and reach out to those patients. They also act as a liaison in between all of our departments. So we do offer, of course, medical, behavioral health, psychiatry, substance use services, dental, optometry, low-cost prescriptions, all of those options for our patients. So it's nice that we can refer them a lot of times internally, but that's not always possible. Sometimes there's things that those patients need that we refer to some of our closest community partners. And just to talk a bit about them. So, we're in Oklahoma. There's lots of Native American names here. So Kai Boys is how that's pronounced. And it's actually the combination of 2 words, Kaimishi and Sandboys, and those are 2 mountain ranges here in the southeast part of Oklahoma. And so Kai Boys is one of our closest community partners. They actually were very instrumental in getting us funded to be a community health center back in 2005. So we're a pretty new company, and if you can think in just a little over 15 years to be able to help almost 30,000 patients, that just really goes to show the need in our service area for patients that really need help with a lot of different services. So Kai Boys as a community action foundation, of course, they do receive some federal grant dollars to focus on many different programs. They offer the transportation service in our area. There are, we call them CATS buses, the Kaiboy Area Transport Service. There's CATS buses going in and out of our facilities all day long. And that's a great service for those patients that have transportation barriers. They do assist in some veterans programs. We do offer services, urgent care, and any other kind of benefit that a veteran may need. If you can think of where we're located here on the eastern part of Oklahoma, we actually, a couple of our counties border the state of Arkansas. So there's not a lot of veteran services in our area. So we have partnered with the Veterans Administration to offer those programs, and Kaiboys acts as a liaison, especially with housing needs for our veterans, medication benefits, et cetera. They do have some food pantries. They also offer the RX for Oklahoma program, which is a program that partners with all the different pharmaceutical manufacturers, kind of a prescription assistance program per se, for those that really cannot afford medications and maybe they need a name brand medication that they can't pay for. So they're a wonderful partner, and I really don't think that we could do what we do here at the Health and Wellness Center without them. The next I have there on the list of key partnerships is the Oklahoma Department of Human Services. They are basically the liaison between our state Medicaid agency, the Oklahoma Healthcare Authority, and those that need to apply for Medicaid. They kind of are the intake for that. Within the last month, I will say that many of the DHS offices in our area have closed. In the counties that we serve, 2 of them have actually closed. Pardon me. And that is because our state is constantly battling a budget crisis. And of course, with COVID, a lot of people were working from home, and the state just said, you know, those eligibility workers can continue to work from home. And we've partnered with them to allow them, them being the employees there at DHS, to use our facilities if they need to. Maybe, you know, they are doing a visitation with, you know, a parent whose child is in the child welfare system, whatever it may be. We're really a close partner with them. Then, of course, there's the Oklahoma State Department of Health. With everything COVID, they are kind of the go-to agency in our state. They do a lot of the contact tracing. If we are out of tests, which has certainly happened, we will refer them to our local health departments, the patients, to get testing there. And all the labs that we work with in the state go through the state health department so that they create the dashboard on their website and report how many positives we have. But they do a couple of other services as well. You know, they also do a lot of the WIC programs in our area, and some other things. But some of the additional partners that we really work with on, you know, linking services for our patients that have some issues. You know, our local community health coalitions, of course, we're not meeting as we used to pre-COVID. You know, COVID, of course, I'm sure all of you have been greatly affected. So, you know, our community health coalitions are really kind of key in each of our communities that we serve as the go-to resource base for really anything health related. So, you know, it included, you know, hospitals, the health departments, of course, DHS, some of the private medical providers and behavioral health providers. So a lot of those meetings are being done kind of like we're doing today, just virtually. And so we're still able to connect patients with services that are offered. Of course, all of our hospitals in our area, being in the rural part of the state, many of you know that maybe in other rural areas know that our hospitals especially are struggling. And in the communities that we serve, when we first opened our clinics, we had 5 hospitals that we worked with in our service area. And unfortunately, 2 of the 5 have closed. So that really kind of makes us need to be stronger for those patients. They don't have access to emergency rooms, but those existing hospitals are certainly very key in helping us take care of our patients. We have great partnerships with local detention centers, law enforcement officers from local police to our county sheriffs, our public schools, which I know there's a lot of discussion right now. What will school look like when the kids go back? Here in Oklahoma, they usually start back the second week in August. We'll see how that's going to look. I know my kids are anxious to see how that's going to play out. So, and then also we have 3 junior colleges in our area that we partner with. You know, kids first going to school, moving away from home, struggle with, you know, where do I go if I need help? And so we're a great resource for our local schools as well. So, and last, I want to jump off here and give Dr. Revens her turn for sure, and allow time for questions. But you know, all of that data that we collect, you know, through our EMR, we use Greenway Entergy, by the way, is the EMR that we use. That all the FREESIA information goes into the EMR, and then of course we report out of our EMR. All community health centers that receive funding through HRSA have to report those things on our Uniform Data Systems report and the annual report that we submit. And they look at all of those social determinants of health, you know, homeless, veteran status. I'm sure there will be a lot of other things per COVID that we'll have to report on. We are accredited through the NCQA as patient-centered medical homes. You know, we have to report through our ACO on MIPS through CMS. So all of those things that we capture, we do report on. So I will go ahead though and turn it over to Thad so he can introduce Keri, and we'll go from there.
Thank you so much for that, Brooke. Appreciate your insight. A bit of housekeeping. I did make it so that you can turn your video on, I believe. Dr. Revens, you should be able to do so as well. But I wanted to pose a question that came up in Q&A very quickly to you, Brooke, because it is specific to your presentation. Deborah is curious what the qualifications are for the integrated care specialists.
Sure. So they are not licensed. They do not have to be. Some of them, like I said, are licensed practical nurses. Some of them have case management certifications through the Oklahoma State Department of Mental Health and Substance Abuse. But really, they just have to have a heart and a want to help. Our job description is pretty open. They do get some training internally and with some of our external agencies as well. But it's really just a program to kind of act as a bridge in between our departments and our community resources.
Awesome. Thank you so much for that. And with that perspective from a leader at an FQHC, we'll now hear from Dr. Keri Revens, who is the Director of Research and Evaluation at a community organization and low-cost medical clinic, the Camino Community Center in Charlotte, North Carolina. Dr. Revens, the floor is yours.
Hi, everybody. Thank you so much for allowing me to be here today. I'm really excited to speak with all of you about Camino, the work that we do, and some of our holistic approaches to healthcare. So just a little bit about Camino. And before I get too far into this, Thad, would you mind advancing to the next slide with the Camino information, please? Thank you.
Of course.
Thank you. So just a little bit about Camino. So first of all, we're located in Charlotte, North Carolina. So we mostly serve Mecklenburg County, which is the county that Charlotte is located in. We do serve people from some of the surrounding counties like Cabarrus, Union, and Rowan. But right now, about 98% of our patients are actually coming from Mecklenburg County. And so it's mostly urban communities that we serve. Camino's mission is to equip people to live healthy, hopeful, and productive lives. And along that mission, it kind of shows that our services really fall into those three buckets of health, hope, and economic opportunity. So I'll talk just a little bit about what our service areas are. So with our health services, we have a primary care clinic that Thad mentioned is a low-cost healthcare clinic with providing acute care as well as some chronic disease management. We also have a behavioral health program where we're able to provide individual and group counseling. And we also are in the process of expanding our nutrition and fitness programming to develop an integrated nutrition and physical activity program called Camino Fit. We do have a fitness center with equipment and group exercise classes, and we're working to integrate that program more into the primary care clinic and behavioral health service so that we're able to work with patients one-on-one to help them manage their symptoms of chronic disease as well as symptoms of behavioral health disorders through nutrition and physical activity. With our Hope services, you'll see all of these listed here under the internal programs on the screen. So with Hope services, we do have a food pantry and a thrift store. We also do a families in crisis program, operates mostly through our thrift store where we're able to help families who are experiencing some type of crisis, whether it's a job loss, losing their house or belongings in a fire, being homeless, lots of different situations there. We try to help people have the resources and things that they need. And then our economic opportunity services, we do some job training and some financial literacy, language classes, and things like that to try and help people advance their skill set that would help them get a job. So I want to speak just for a few minutes about the population that we serve because it's very important to talk about with some of the things that we're doing. We serve a very unique population. About 98% of our patients at Camino Clinic are actually first-generation Latino immigrants. Most of them prefer speaking Spanish and have very limited English language ability. The reason I mention this is because this really is telling of how our services are implemented and some of the needs that our clients have. So we are serving a population that experiences significant barriers to accessing healthcare and any other sort of health and human services. So if you think back to that first slide presented about the social determinants of health, I'm going to talk about some of the barriers our clients face in terms of those social determinants of health. So the first thing that a lot of people often think of are language and cultural barriers. So specifically in Charlotte, North Carolina, there are very limited places where people can go and receive bilingual services in English and Spanish. So Camino is one place that's able to offer that. There are also often barriers as it relates to culture, especially when you're thinking about medical care or behavioral health care. And along with that, Camino has worked for over 20 years to establish itself as an organization that is trusted in the Latino community. So Camino has really become this sort of go-to name in the Latino community for a place to go where you can have bilingual multicultural care. Other barriers that our patients face have to do with their immigration status. We have over 100,000 immigrants in Charlotte that are not documented. So this is really going to affect the level of care they're able to receive and the level of trust that they have going out and asking for help or seeking out services. A lot of our patients report that there are times when they're afraid to leave their house because they're worried about possibly getting in trouble or something that could result in their being deported because they are undocumented. So that's just another layer that adds to the difficulty in accessing services for this population. Again, I believe because of the trust that Camino has developed, we're able to overcome that barrier. 100% of our patients do not have insurance. We actually don't even take any insurance right now at all because our patients are uninsured. So we're able to serve them regardless of insurance status, regardless of documentation status. Other barriers for our population have to do with transportation. We do have public transportation in Charlotte, but it's still lacking. And if you live in rural areas, it can still be very difficult to access services. The Latino population is also at an increased risk for food insecurity. And we have saw this, that our population has been disproportionately affected by this as a result of COVID-19. So through our food pantry, we saw an enormous increase in the demand for food as the COVID-19 pandemic hit. It's also worth pointing out that this is likely because a lot of the people that we serve have lost their jobs as a result of the pandemic. We know that a lot of Latino immigrants work in service-related and industry jobs where they may have been mandated to close temporarily or even permanently. So we've seen a lot of people lose jobs and experience economic hardship that they weren't experiencing before. So all of those things just make it more difficult. So as you think about that, you know, we had to get creative in some of the ways that we serve this population and the things that we do. So there are several things that make us unique. I've mentioned that we're bilingual. We're actually on the verge of becoming trilingual. We have a staff member who is from Brazil and fluent in Portuguese. So she's in the process of converting all our materials to Portuguese to allow us to have 3 languages, which is very exciting. We're also multicultural. We have staff from various Latin American countries, and we serve patients from 15 different countries throughout the Caribbean, South America, and Central America, and Mexico. We've taken that time to establish the trust in the community, but that's something that we continue to work on. We employ staff members who are, like I said, multicultural. Many of them are Latino themselves and can really take the time to establish those relationships of trust. We also do events in the community that just simply give back to the community, which I believe is another way we've established trust. For example, in August, we have our big back to school event coming up where we supply kids with backpacks full of school supplies for school. We also have music, events, food, all kinds of stuff. The structure of this event is changing. As we know, everything is changing right now because of COVID-19. And we are moving to a drive-through model, just to give you an idea of one way we're adapting some of our things here. And I believe that Camino has always been mission focused, and we let the mission lead us rather than money. We are not a faith-based organization, but we do also have a church, which is a separate organization called Camino Church. And there is a lot of synergy between the church and the community center as well. So we're able to utilize volunteers through the church to accomplish our mission and to fulfill some of these services where we may have gaps in staff. So as I mentioned, when COVID-19 hit, we really saw a huge increase in the demand for food. But we also quickly realized that it wasn't just food, that people's needs were extending way beyond food, including a lot of basic needs. We saw a huge need for diapers and baby formula and things like that. And so we quickly realized we needed to do something to ensure that we were better, doing a better job of identifying the different social determinants of health and how to address them. So we recently implemented a social navigation program where we have a trained social navigator similar to what Brooke was describing in her presentation. And we also have an assessment that, again, is similar to what Brooke mentioned. I adapted an assessment for us to use specific to Camino because we do serve such a unique population. So there are some questions on it that are specific to Latino immigrants, but it was adapted from the Prepare assessment that Brooke mentioned and a few others. So I'm sure that a lot of the questions are very similar, but it assesses the needs for each area of social determinant of health. And what we're then able to do is refer our patients internally for the services that we provide, and then externally for the services that we do not provide through our community partners, which I'll talk about in just a few minutes. Our plan right now is to assess this every 3 months with those who have needs, to continue to follow and track them and see how we're improving and meeting those needs. We also implemented a ranking system to basically score the needs from no to minimal need to high need. It's basically using a 1 to 4 scoring system so that we can also try to prioritize how high the needs are, who needs the most help, and that sort of thing. I'll be honest, right now we only have 1 staff member trained to do this, and we're utilizing volunteers from the church, as I mentioned, who are also trained internally, but we're in the process of trying to obtain some funding so that we can expand that program. One of the things that we have definitely learned along the way doing that program and any of the programs that we do is the importance of data and outcomes. So I think it's important to think about the assessment, the Prepare assessment, or whatever assessment you choose to use, and make sure that you're collecting that data so you have empirical data to be able to tell the story, show the impact you're making in the community, and that's also something you can use for funding opportunities, which we've been able to do quite successfully. But speaking of the social navigation program, again, we refer internally when possible, but we realize that we can't do everything. We want to focus on certain areas and do them well. So we have several partners who do some of the other things that we're not able to do and that are really integral in the work that we're doing. So you see several of the partners listed here, and there are a few that aren't on there, but I'll just go through these pretty quickly. I don't want to take up too much of our time. But our first partnership on there is UNC Charlotte. This is our local university. It's actually 5 miles away from Camino, which is great, you know, location-wise. But the university is absolutely critical in so much of the work that we do. So we have, we work with several different faculty and students through various departments at UNCC to implement our programs. For example, our behavioral health program really got started strictly through UNC Charlotte. Faculty and staff came together with leadership at Camino to help develop it, and it was completely student ran in the beginning, meaning that interns from from counseling and social work and health psychology graduate students were basically providing the counseling as part of their internship, and we're able to do it for our clients for free or for a very low charitable donation. So that's just one example. We've since grown and expanded, and we have staff at Camino that we were able to hire largely through grant funding initially as a result of the data that we collect from that program. UNC Charlotte is also helping us with our Camino Fit program, which is the integrated nutrition and physical activity program. So they're just a very great resource. They can lend expertise in things that we might be lacking. They also can assist with data collection, program evaluation, and grant writing. You also see the next one listed there is Loaves and Fishes. We are a part of the Loaves and Fishes network for our food pantry. So we're able to get the food for the pantry from Loaves and Fishes. And during COVID-19, we've increased that from 2 days a week to 5 days a week, allowing us to serve approximately 12,000 individuals per week. And in comparison, we were serving around 100 to 200 per week prior to COVID-19. So we've really stepped up the food pantry, and Loaves and Fishes has been a huge part of that. Blue Cross Blue Shield North Carolina is a great partnership for us. They have provided funding as well as some expertise in programming for some of our nutrition and fitness programs. American Heart Association as well. They are doing a community health workers program that they've partnered with us to implement through the Latino community. And they're also a great resource in terms of giving us supplies like blood pressure monitors and other things that we need for our clinic. We are a member of the North Carolina Association of Free and Charitable Clinics. There's also a National Association of Free and Charitable Clinics. So I encourage you, if you're not already, look into becoming a member of the national and of their state chapter if possible. We have been able to get grant funding through this association to support staff and to subsidize some of the cost of patients that can't afford to pay for their visits. We partner with Cardinal Innovations Healthcare for our behavioral health program for resources and support. And the last two there, Novant Health and HRM Health, those are the largest hospital systems in North Carolina. And we partner with them to be able to provide services at our clinic like mammograms and an OBGYN clinic, where they volunteer staff to do that, where we would really not be able to do that without them. An important partner that I accidentally left off here is Mecklenburg County Public Health. They are a great partner for us as well, especially in helping to fund our low-cost clinic and providing us with funding that allow us to keep the cost down for our patients. So we do charge a small donation, ask for a small donation from patients, and we have a low-cost membership program, but the patient cost is very low, and it's we incur quite a lot more cost at Camino. So we're able to subsidize some of those funds through the county and some of those other partners I mentioned. The last thing I really want to touch on, and I've hinted at this already, is about our reporting and data collection. So my role at Camino is actually to oversee all of our outcomes and data as well as our grant writing. So this is really my world and my area of expertise, and I'm happy to give my information if you guys have additional questions after this and want to contact me via email. Listed here are just a few ways that we collect data specific to the clinic. So we do use clinical outcomes measures that we are able to extract from our EMR. Brooke mentioned the EMR that she uses, and I hadn't heard of that one, and I would actually be interested to learn more, but the EMR that we use is called Practice Fusion, and we're able to use this at no cost through the North Carolina Free and Charitable Clinics Association. So another example of how they're a great partner for us. But we're able to track our clinical outcomes, for example, blood pressure numbers, A1C for our diabetic patients, track those over time and see how they're improving as a result of the care we provide, as a result of the nutrition and physical activity programs we provide. We also implement we regularly implement a patient feedback survey, which is an existing valid and reliable survey that has already been tested and is used across a lot of hospital systems like Novant. This asks questions about their provider experience, their overall experience there, whether they would recommend, the service to someone else. So this is just more getting at what has their experience been like and how can we improve. I would say collecting data, being able to measure your outcomes is one of the most powerful tools that you can use for grant writing. If you are like us and you need grants to keep some of your programs going, that's something that can be very, very powerful. Incorporating research and incorporating empirical data into grants can help boost your chances of getting them. Just to give you an idea, since December until now, Camino has gotten almost $1 million in grants, some related to COVID-19, some related to normal operations and ongoing programs. But we do feel that we've been successful in obtaining local and national grants, and I think that it is attributed to the fact that we use data and are ensuring that we're constantly engaged in quality improvement and how we can improve the services that we provide. So I'm going to stop right there because I don't want to go over my time, and maybe I already have, and if I did, I apologize. But thank you so much.
Well, thank you, Dr. Revens. I love hearing from organizations like yours where these social determinant programs and community partnerships are so integral. But before we move on, I wanted to pose a question to you. A few folks are interested in the assessment that you had mentioned. Is that something that was developed internally? And I apologize if you had already mentioned that and I missed it. But would you also be willing to share that assessment with folks?
I'm sorry, was that a question for me or for Brooke?
That question was for you, Keri.
Okay, so what we took the PREPARE assessment and a few other assessments that were already existing and combined them into a very comprehensive assessment that we felt met all of our needs. And we did add some specific questions to the population that we serve. So the instrument as it exists right now, the way that we are using it, to my knowledge, hasn't been used anywhere else because we did add those extra questions. That is something that I can definitely share if you're interested, but we are just in the beginning phases. So I want to be very honest with all of you in the fact that we haven't yet tested it. However, most of the questions have been previously tested for validity to show, that they're actually asking what they're intended to ask. So, but just to be completely transparent, we are just starting to administer it and we have not yet tested some of those questions.
Perfect. Thank you very much. Mary Golden also had a quick question. First, she asked if you'd be willing to share the assessment, which we've answered, but she's also interested in how you go about deploying the patient survey and if there is an opportunity for you to share that as well.
Sure. So for those who are interested in the assessment, I would ask that you do reach out to me directly, just so I can learn a little more about how you plan to use it and, the work that you're doing. So I'll leave my contact information and you all can email me. With the patient satisfaction survey, our clinic is still currently open. So we do still have patients coming in for in-person care and are able to complete the survey when they come in for their visit. We're hesitant to do something like that or some of our instruments electronic because we have seen such a slow, I'm I'm not sure the best way to use it. Our patients have had a hard time adapting to some of the electronic assessments because they're not very familiar or comfortable with technology. So we're having a slow process of sort of transitioning them to electronic. So with the social determinants of health assessment, for example, it is electronic and it's administered on a tablet. And we've tried to make it so it's very easy where they can just click the responses they need. But the patient satisfaction survey as of now is still being implemented in person when they come in on paper right now. We probably will transition that a little bit later, but as I mentioned, we're trying to sort of baby step into that. We've had a lot of our patients talk to us about their difficulty with electronics and technology. And that's also resulted in some of our telehealth. We are doing telemedicine visits, but they've been a slower process. And most of our patients are only doing phone visits by phone without any video. A lot of them don't have smart devices and may not have access to the internet. So again, those are some of those barriers that we need to be thinking about when we serve a low income population. But we have been able to do very successful telephonic visits. So it's possible that we could transition the patient satisfaction survey to a telephonic survey in the future.
Thank you so much. And sorry for springing those questions on you, putting you on the spot. But before we do kind of move on to our roundtable discussion, I'm going to allow Jeremy to give a brief announcement here.
Thank you, Thad. Yeah, like Thad said, just a quick announcement and we can get back to the discussion. I've been working alongside Thad to get this project up and running, and we have another new community feature to announce that we're really excited about. If your organization is already using the Care Message platform, we want to invite you to continue today's discussion. We're sure there'll be more questions after we run out of time here today. And you can continue that discussion on our brand new Care Message community forum. You can visit this forum at the URL shown here, community.caremessage.org, and we'll send out more information after this. Once you sign up for an account from the homepage using your Care Message email, we will verify your email, approve your account, and then you can get started right away. Our goal for this forum is that it will be a space where you'll be able to interact with Care Message users from across the country, free clinics, FQHCs, everyone, and guide each other to learn more about what everyone does well and what everyone can improve on. So we hope that we can share resources here, ask questions, and have conversations with each other about social determinants, COVID-19 strategies, and how to leverage our patient engagement tool to meet the needs of your patients. So yeah, we think this is going to be a really exciting opportunity and hope you join us.
Awesome. Yeah, I'm excited for that as well. Like Jeremy said, I'm sure there's going to be a lot of additional questions, and I'm sure that Brooke and Keri would be happy to join us on the forum as well, so we can all interact there as well. So we're going to kick the roundtable discussion off with a couple of questions that came through in the Q&A button, but please do raise your hands in Zoom if you want to voice a question. If you'd like to speak, we can go ahead and unmute you and we can kind of have a conversation that way. But we can jump into a question that came in from Michael Knudsen. I hope I'm saying that correctly. But Michael, if you'd like to ask this question aloud, we would certainly invite you to do so. If you want to raise your hand in Zoom, I'll give you a couple of moments to find the button if you're interested. And if not, no worries. I can go ahead and read it aloud here. Go ahead and read it for you, Michael. The question is, it's not specific to Brooke or Dr. Revens, but the question is, sorry, it just disappeared. How did you develop the trust in the community? Where did you start? And what has been something key to outreaching and developing rapport with your patient populations? You can open that question up to both Brooke and Dr. Revens. How do you go about reaching out to the community and developing rapport. How do you think about that?
I'll go ahead and add something to start because I know I talked about trust. So our organization started over 20 years ago, and one of the key things, really the reason that everything that we did got started is because our founder and CEO is a preacher and a missionary, and he was doing missionary work in Cuba and other Latin American countries, and realized very quickly that there was a need here in Charlotte. He had a friend who was sick, went to the hospital, basically language barriers, not having insurance, a lot of different factors that played into it. But as somebody in their mid-30s ending up passing away from a heart attack, from something that we felt could have been prevented with the right type of care. And it sparked this idea that, hey, we need to have a clinic, a place where people can go to get culture-friendly services, whether they have insurance or not. In terms of the trust, what they saw from there, I wasn't around back in the very beginning, but I've heard all the stories and all the history. But after the clinic, all of the other services really started to just come up organically from community members themselves. So members of the Latino community would identify a need, like food, for example, and say, maybe we could do a food pantry, and they would just start collecting donations to have a pantry. Same thing with our thrift store. A woman and her husband who had recently moved here from another country wanted to be able to do something to help families who are just, when they first move in, are getting started and don't have anything. So they started taking in donations and doing a thrift store. So I think one of the ways we develop trust is that the services and the programs came directly from the community themselves rather than from outsiders coming in and saying, here's what we need to do. And having those people who are a part of that community, being the ones getting things started and doing the outreach really goes a long way for trust, so that somebody can come to Camino and say, okay, here's a person who can speak my language and who looks like me, who is also an immigrant and who can understand some of the things that I've gone through. So having that, those people that can relate. I think other things that we do are just showing that we have the heart and the passion to help people, that there's not really a greater reason behind what we're doing, and we're not in it for ourselves, that we're in it truly to help people. And I think over the years, people have seen that through different events we do in the community, like the back to school event I mentioned. We also do an event at Christmas where we give every kid that comes a gift, and they get to see Santa and do all the fun Christmas stuff. So there are a lot of events that we do that are just for the community. And I think over time, people have come to learn that if they come through our doors, they will get help one way or another. A lot of it comes down to the heart of our staff. They are very dedicated, and they will figure out how to help a person, even if it's not a service that Camino provides. I know staff members that will drive people to other locations and be on the phone translating for them in Spanish, trying to see how they can best help them. Our founder and CEO has more than once taken in families in his own roof, let people sleep at Camino, just doing that pure heart missionary type work. And I think that spreads. So a lot of people hear about what we do through word of mouth, and I think they hear these wonderful things in the care that are behind all of the services. But some of the basic things, just language goes a long way, having people that can speak the language and being sensitive of culture. We do a lot of events where we make sure we have foods from all different countries. Again, the community members make the food, they're a part of it, letting them be a part of everything that we do and having a voice and meeting people where they're at and seeing how we can help them no matter what resources they have or what they have to offer.
Thank you, Dr. Revens. Brooke, anything to add there?
I think that trust is just built over time, and as you prove yourself as an organization, and kind of like Dr. Revens said, just as need arises in our communities are all very different. What's best for one may not be what's best for the other. So we just really have to be in tune with what's going on in our communities, and continuous ongoing support and care just builds trust over time. So. Thank
you both. I have two questions kind of grouped together here. One is from Douglas Price. The question is, he would like to know how both of your organizations are funded. Are all of the services free? Are there significant private or corporate donations that you receive, foundation grants? And then along the same lines, with regard to revenue, an anonymous attendee asks if or how you have been able to maintain your revenue stream during the COVID-19 pandemic for staff and program costs.
Do you want me to take that one first, Dr. Revens? Okay. So as a community health center, we do receive some federal dollars from HRSA, the Health Resources and Service Administration. And every penny of those grant dollars must be spent on patients that are either uninsured or underinsured. And if you can consider underinsured, those patients maybe that are getting help through the health insurance marketplace, through the Affordable Care Act. A lot of those plans have very high deductibles, so it would be almost impossible for a patient to meet that deductible, especially for their primary and preventive care. So of our almost 30,000 patients that we take care of, about 20% of them have no insurance or are underinsured. And so that's where those federal grant dollars come in. It's only about 17% of our total operating budget, so we're not solely dependent upon them, but it does help us pass that cost savings on to patients that otherwise might not be able to get care. So we're not a free clinic. We don't market ourselves that way. We do want the patients to be responsible for their care. I think it is the belief of our mission that if you you pay for something, you tend to value it more, and you tend to be more engaged in your care. However, as a community health center receiving those federal dollars, we cannot turn anybody away based on their inability to pay. So we do have a pretty significant write-offs every quarter, but that's where those grant dollars come in. Now, I mentioned about 20% are uninsured. We have about 50% of our patient population that has Medicaid. Here in the state of Oklahoma, it's called Sooner Care. A lot of those are children, and then for an adult to be eligible for Medicaid in Oklahoma right now, they have to meet criteria, of course, income, and then either be pregnant, under 18, over 65, determined disabled by the Social Security Administration, or be on the TANF program, the Temporary Assistance for Needy Families, basically. Parents that have minor children living in the home with little or no income, and they're on a work program. We did just recently pass the end of June 30th, State Question 802, which the people voted to get the Medicaid expansion. It's not going to be called that in Oklahoma because it's political. However, we're really excited because that's probably going to give about 200,000 Oklahoma residents, it's called the Healthy Adult Option, access for the working poor to have some kind of coverage. So that's great. So if you can see about 70% of our entire patient population is pretty marginalized and really struggling to make ends meet. The remaining 30% is pretty equally divided amongst private insurance, Blue Cross Blue Shield, Aetna, United Healthcare, whatever it may be, and then Medicare. So our funding, our federal funding comes from HRSA, and then we have other income through different revenue streams that we use for our patients. So. Do you want me to answer the COVID question too real quick?
Sure, yes, if you don't mind.
So we are fortunate that we have a great telehealth program. We've had it actually for several years. And when we went into emergency operations March 17th, we had to get additional licenses and additional equipment. A lot of our providers started working from home, medical and behavioral health. And so that allowed them to still have connection to their patients. Of course, we're in a rural area. It wasn't always feasible for them to have audio and video. A lot of it was telephonic. But it was great because the patients and the providers both saw that it can happen. And so it's really grown our telehealth program. Just to give an example, last year we had about 3,000 telehealth visits. In the end of March and all of April, we had almost 3,000 telehealth visits. So, our productivity was certainly down as much as 40% at one time early on in the pandemic, end of March, 1st of April. But we're slowly but surely getting back. So it's just how we operate, I would say, in our clinics more than anything, with having to screen and, making sure that we don't have too many people in the building at once, and, red carpeting them back to an exam room so they're not sitting in the lobby, and escorting them out. Just making sure, that we keep everybody social distance. And of course, PPE is a requirement. So hope that helps.
Thanks, Brooke. And I'll just add just a little about Camino. Some of it is similar. So in terms of COVID-19, we too have started some telehealth services, and this was really our first experience, one of our first experiences with that. And I spoke about that a little bit before. So this really gave us that extra push that we needed to try and start doing some telephonic services, both with the primary care clinic and behavioral health. However, our clinic is still open 5 days a week for patients to come in if they're sick or they need care. One of the biggest impacts of COVID-19 is that a lot of our patients were canceling their appointments. We're a low-cost clinic, so none of our services for the clinic are free. So there is a small copay for that. And so a lot of our patients weren't able to afford it, so they were just canceling their appointments. We have been very fortunate in securing several COVID-19 relief grants that have helped us pay for those patients who couldn't afford to pay because of COVID-19. We got a grant from the North Carolina Healthcare Foundation specifically to help these patients. In terms of our normal clinic operations, it is a low-cost program. So we developed a membership model last year that we implemented in October, where patients pay a yearly membership fee and then a small copay for each visit. So it's still, the cost is very reasonable compared to other places, but it still allows us to generate a little bit of revenue from the patients themselves. We also have an annual contract from Mecklenburg County Health Department where they give us funds specifically to pay for patients who are not insured, and all of our patients are uninsured. So we have a couple of continuous sources of revenue that we get annually. As I mentioned, we're also part of the North Carolina Association of Free and Charitable Clinics, and they also give us funding to help support those patients who are uninsured. We do rely on grants. So we've several different grants for the behavioral health program. We received a grant for the social navigation program to pay the salary of the staff. And so a lot of times we rely more on grants to help us get things started. And then over time, we're able to sustain those services. So the membership model is one way that is very helpful for us. We also get revenue through the thrift store. That's one of our only services that doesn't cost us a lot of money, but we're able to get revenue through. We also have a very strong presence in the community, as I mentioned. So we have a director of community partnerships who works to establish and enhance those relationships with community partners some of them are continuous donors. So we do rely on some corporate and personal donors. And we have a couple of churches in the area that have just really gotten to know the work that we do and are very invested in the work we do and have given large donations over the past couple of years. When COVID-19 hit and we saw this huge increase in the need for food and people losing their jobs, we did launch an online fundraising campaign through mobile calls where we were able to raise about $700,000 that way $70,000, sorry about that, $70,000 that way through donations. Some of were corporate, but a lot of them were just individual donations, mostly to help out for the food pantry. So we have several different ways that we do rely on grants and then donations, as well as some continuous streams of revenue.
Thank you both. Unfortunately, we are right up against our time limit here. And I know that we didn't get a chance to answer all of the questions that people were sharing in the Q&A. So what we will do is share those questions with Dr. Revens and with Brooke via email, and we will reach out separately to you if you did pose a question. Just very quickly wrapping up here, some final housekeeping notes. We will be sharing out the link to the recording as well as the slides via email this afternoon. So please feel free to share that link with anyone who might find this session valuable. And our plan going forward with regard to a continued conversation around social determinants will be to dedicate the same amount of time to a deeper dive into a specific cause area. So if you are interested in sharing your story or your organization's strategy when it comes to one of these social determinants of health, please do reach out to us via email. Thank you so much, Brooke. Thank you so much, Dr. Revens. We really appreciate your insight. And if anybody has any questions at all, you can always follow up with us directly, and we'll be sure to get in contact with either Brooke or Dr. Revens on your behalf. So thank you all so much for taking the time out of your day, and have a great rest of your day.